Okay, so as everyone knows right now, we're dealing with coronavirus, so we are bringing to you our classroom from Shelley's Nursing Review, and I'm Dr. Shelley Bevel. So we're talking about electrolytes today. You will need several handouts, and if you are currently in nursing school, I just want to give you a couple of tips to be able to pass this test. Most of the students use this textbook. We call it IGGY, if you will. So that's the textbook that I recommend as well, and this is what I use when I'm preparing for lectures for different classroom instruction. Even I use it for when we teach medical students as well as PA students or nurse practitioner students. So it's just a good overall textbook. Now the handouts that you need, there are two of them. As you know, my Shelley's Nursing Review or CNR program runs off of the Oh My God packet. It is my entire curriculum. There are books available that have everything that I've ever created for you. If you want to purchase those, let me know. You can text 216-410-0936 and you will get pharmacology, procedures, this Oh My God packet, which has labs and everything in it. You will also get the infectious diseases, which talking about coronavirus is a big deal right now. How to put on the PPE, what PPE do you need for certain diseases. That is also included in that book. And then the big one, of course, is management of care, your prioritization, your delegation, your who to see first, your who not to see first, who to put in a room with the person. Again, those are available for purchase for $49. And you can just text me 216-410-0936 and get that all in an actual booklet, which I'll be showing you on the second half, just to go over what's available in our program. Now, as I stated, this is an electrolytes lecture. My board is the magic board, I call it, and you will need two handouts. You will need the Oh My God packet, and you will need to turn to the Miss Piggy section of your Oh My God packet, and I will tell you that that is actually on page 8. Okay, so you will need to turn to that page. I'm going to actually come up a little closer so that Larry can get this on record. And so I'll come up a little bit closer and you'll be able to see that this is page 8 of your Oh My God packet. The other handout that you will need, and I'll be coming back and forth up to the camera a little closer for you to see, is this packet here. It's called the acid-base imbalance. If you could do me a favor across the top so that you remember what it's for, just write big as you can stand it, electrolytes and acid-base imbalance. Now we can get the party started, as we say. You will start with your notes on the front page. What I have instructed students to do, because otherwise they're going to be lost and they're going to be looking somewhere other than where I really want them to look, is to write everything down on the packet. It's very hard when students write things down in notebook paper and then they go back to this and they're looking at their notebook paper and then they go back to this and they look at this. You're missing everything I'm trying to tell you. You're also rewriting things that have already been written, and you should be actually highlighting things, okay? So I have created packets and bought these packets for the use of instruction, so let them help you. They're very good packets. So on the front page, we're going to get started with the lecture. And with the front page, I want you to write, first of all, the fact that electrolytes are very difficult in terms of a test in school, but they're very easy in terms of what you have to know for bigger tests like an NCLEX exam or a PA test or whatever. So what is so important to remember is that electrolytes in general have two issues. One big one, but two issues that apply to a lot of electrolytes. The biggest issue that applies to electrolytes is that they control muscle action. And so when you have an electrolyte issue, it's an issue about muscle weakness. No matter what the electrolyte is doing, whether it's high or low or whatever, it's usually going to be a muscle weakness issue. The other issue can be, not 100%, but it can be seizures. Seizure precautions may need to be implemented for patients with electrolyte imbalances. Now, the last thing, which is not written up here, but you'll see me mention it quite a bit, especially with potassium and sometimes magnesium, is that whole EKG dysrhythmia profile that you can get with, abnormal electrolytes. Now, so let's come with me. Let's go. Let's start this whole journey. Now, so if we look at the first electrolyte, you will need to turn in your packet until you get, and we're in this packet right now, you will need to turn in this packet until you get to a page that says potassium levels in acidosis. This is where I start this lecture. I also start the lecture with your potassium, sodium, calcium, phosphorus. I kind of go with potassium because it's the most important thing on earth. And if you have a deficiency or too much, we're going to have a heart problem, correct? All right, so that's first. Now, once I teach you about potassium and some specifics, we will go back to the front page and put some notes that have to do with electrolytes in general, specifically looking at potassium, but a little bit in general as well. So here we go. Whenever we're talking about potassium, and we're looking at this page and it says potassium levels in acidosis, I want you to take this page where you see this wonderful K, and I want you to go ahead and on my page you will see really cool coloring. I'm not gonna lie, I kind of like to color, okay? You're gonna just have to pray for me because that's the child part inside of me. And if you look at this page, you will see that I have colored all kinds of fun things. I've colored the fact that the potassium issue is seen with DKA, AKI, and CKD. In fact, I have chosen to put the K and the K and the K in red because in diabetic ketoacidosis, in acute kidney injury, in chronic kidney disease, all three of these have a very high potassium. And that very high potassium is a big deal. So we know that almost most tests that you'll take will focus on a high potassium. It doesn't matter if it's high or low, you will absolutely need an EKG. Also, there are three organs that are affected: heart, GI, renal. Those are the three body parts that are affected. In particular, again, we got to go back to that issue about muscles when it comes to the heart and the GI system. In the GI system, your muscles move. It's called peristalsis. And of course, the heart is one big muscle. So when you don't have potassium, or if there's an imbalance, that's why you have to have an EKG, because it absolutely is going to affect the heart. For the GI system, it's very simple. If the muscle moves too much, you get diarrhea. If the muscle doesn't move enough, you get constipation. So if potassium affects muscles, well then a high K is going to be diarrhea, and a low K, which means your muscles aren't really moving, is going to be constipation. I mean, we got this. We can do this. All right. Now, so that is just potassium. Now, there's something I want to tell you about potassium that you may or may not kind of know, and hopefully I'll give you a little bit more instruction on it to clarify things. There's something called intracellular, extracellular, and interstitial. So if you just kind of hang out with your girl, I'm going to go over here, which is far away from the camera, and I'm going to get an eraser. This eraser, I'm going to kind of erase some of the things that we've already talked about today, and I'm going to make a blood vessel. This blood vessel, as you have heard if you've been in my class before, contains little red blood cells. And when we look at little red blood cells, hopefully Larry is able to catch some of these red blood cells on the board. I don't know. I hope you can see them kind of close. But they have a potassium inside every cell. And I said a potassium, but that sounded crazy because technically it's potassium in every cell in your body, like a lot of it, right? It's the normal amount, but it's in every single cell in your body. It's called intracellular. So the most abundant, we call it intracellular cation, if you want to remember that word. The most abundant intracellular cation is potassium, okay? All right, now stay with me. The opposite of potassium is sodium. So you're going to see me draw sodium in this blood vessel, but it's not going to be inside the cell, it's going to be outside the cell. And sodium or salt is married to, you guessed it, water. So sodium and water are in a marriage, and they actually like each other. So wherever the one goes, the other one follows. Y'all got it? Okay, so get this. Potassium and sodium are divorced. If potassium goes up, sodium's going down. They are going far away from each other in most diseases. Now, you cannot be an absolutist, which means that you say, oh, well, every time the potassium goes down, then that means sodium goes up, or every time that the sodium goes down, the potassium goes up. Oh, I got this. No. You cannot be an absolutist, because if I give you too much Lasix, what's going to happen? All of your electrolytes, right? Your potassium and your sodium are going to go down. So don't do that. Always critically think before you apply the rules, okay? All right, so go along with me a little bit further, and let's look at what I did so far. I said that the intracellular component was potassium. Now I'm telling you that the extracellular component is sodium. Very important. But then I have something else, and it has a completely different name to it. It's called interstitial. When I say the word interstitial, it can be very confusing, so I use a trick, right? I tell you that the interstitial fluid is the fluid in the tissue. Interstitial in the tissue. Y'all got it? Come on, make it work for you. Interstitial in the tissue. Interstitial in the tissue. Okay, oh, you got it. Okay, good. So interstitial is in the tissue. It's not in the vessel. Now, I don't know if you can see it, but I'm going to try to come up close and see if you can see my blood vessel. It's a blue vein, and around it would be considered tissue. If I put an IV in that vein and it infiltrated, then the water would go around the vein in the tissue. This is interstitial area. When you see edema and swelling, it's in the tissue, okay? Now, intracellular fluid, potassium. Extracellular fluid, sodium. Interstitial tissue is just water. Just simple, normal, hydrated patients with just nice hydration status will have just a normal balance of those things. So that should help. Now, whenever, and this is very important, so I want you to take your front page and write this down. If sodium and water are excreted, then potassium is retained. I'm going to say that again because I wrote it. I'm going to show you where I wrote it. If sodium and water are excreted, then potassium is retained. Okay? All right. Now, the next thing I want you to write on the same page is that the intracellular fluid makes up 2/3 of our bodily fluids. Intracellular fluid makes up 2/3, most of our intracellular fluid. The extracellular fluid is only 1/3 of the body's makeup of fluid. So you kind of care, okay? Now, what else is in the cell with potassium? Side note, phosphorus. What you really want to remember is if you have a destruction of the cell, and that's called lysis, then you will have potassium and a little bit of phosphorus come out and be kind of high. Okay, that'll hit you Tuesday. All right, now let's erase some of this so that you can kind of stay with me, because we're jamming, we're moving on. Okay, there we go. Now, when it comes to the labs are pretty easy. You take the 3.5 and flip it, and it becomes 5.3 for your normal potassium. You came into my class from kindergarten knowing that, so I'm not even going to sit here and talk about that at all. What I am going to tell you is that as long as you've understood what I've said so far, you can go back to this page here with the whole acidosis thing, because I want to write something on that page. Lord knows that acid-base imbalances and electrolyte imbalances go together. However, this is strictly an electrolyte lecture, so we are just kind of tying in the acidosis and the alkalosis a little bit as we go. We're not concentrating on those, but if you notice in your package, you have a lot of handouts that say metabolic, respiratory, blah, 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 blah. So let's hang out together, shall we? I'm going to come up close and show you how I did this, because some of you write too tiny and I need you to write really big. Here we go. If you look at my handout, you'll see it says basics of electrolytes. You'll see the potassium levels, and you'll see I did AKI, DKA, EKG. You could have put CKD on there as well, like I did on the board, and you see the acidosis. Now, at the bottom, this is the key. At the very bottom, you have to sprawl all the way across the page and write alkalosis, and this will remind you that all K is low. Okay, that's a trick, and you need to know that trick. I got plenty of tricks. That's what you paid me for, but you really need to know that one, okay? Now, if you wrote it like I told you, we can go on to the next page. The next page has to do with potassium and the general rules about potassium that you have to know. Now, on this page, I get you to write a bunch of no-nos. No-nos mean things you have to remember forever till the day you die, okay? So here's some no-nos. Some no-nos include very clearly that you absolutely cannot give this IV push. I think you know that, but I'm just saying, you cannot give this IV push. No way. It's probably one of the biggest rules that we have for potassium. No potassium IV push. Huge rule, like huge, like ridiculously huge, okay? Now, so if you think about the fact that potassium is very vesicant or strong to the vein, and the fact that if you gave potassium and you didn't know any better and you pushed it IV, you would definitely have some burned or singed veins, and you probably would get in a whole lot of trouble, and maybe perhaps you'd have to retire because you're not going to be a nurse anymore, because that was crazy that you did that. It was stupid. Yeah, it was a little bit stupid. Now, that does not stop your shall we say, your providers, your residents, especially residents, it does not stop them from saying, oh, so-and-so has a low potassium. Can you go ahead and give her some potassium IV push? Oh, that does not stop them. I'm sorry, you thought that residents knew everything? No, that's why they're called residents. They're learning. I hope you get that. Now, so I want to show you a couple of things that's going on around here. I want to give you like a list of things to really remember, like sort of kind of forever. How's that sound? So here we go. No potassium IV push is number one. Never crush potassium. Okay, so you're writing while I'm talking on your potassium handout, and your handout looks just like this. Okay, boom. All right, here we go. Never more than 40 equivalents, milli-equivalents, 40 in a big old bag of IV fluid. Now, do not go crazy with this one. Don't put a star by it. Don't even halfway remember it. It's not the usual thing on a test, but it is important for you to know because normally potassium is mixed by the pharmacist and it has to come up already made. This is a very high alert drug, so it absolutely has to come up to you already made. It has to. It's not like we can negotiate that. But in days like coronavirus, in days like Katrina, in situations like 9/11 or any other national disaster, man-made or otherwise, if you needed to mix potassium in a 1,000 cc bag, your maximum would be 40 to put in that bag, okay? Now, again, that is not to be uppermost in your mind. It's supposed to stay back here somewhere. Now, the next thing, and this is supposed to stay uppermost in your mind, no more than 20 milliequivalents an hour. So I'm going to write that. No more than 20 milliequivalents an hour in a peripheral line, which means a normal old-fashioned IV. It is much more preferred to give this potassium through a central line. So if you aren't doing a central line and you are doing a peripheral line, then you cannot go above 20 an hour, okay? Now, never bolus potassium. Don't open that IV wide because it's on a pump anyway, so that would be like really, really dingy. Never bolus potassium. The next thing is when we use potassium through the central line, then you have to remember you have to do no more than 40 milliequivalents in the central line, right, per hour. Okay, so you go a little bit higher there. Now, how much can go in through the central line? If you are looking at the actual bag, well then that is 80. But the bottom line is the things I've written. No potassium IV push, no more than 20 milliequivalents per hour. This is the time frame, okay? Don't bolus it, okay? So I'm telling you the things that are very important. Now let's give you a few more things that I think you know. It has to be on a pump. The pharmacy is supposed to mix it. It's a high alert drug, so it can kill you when things don't go quite right the way they're supposed to. If you look at your handout, it gives you a lot of other things on it. We'll talk about that in a minute. But again, I'm writing on the packet, the actual handout, all the things that I really need you to know. Before you give potassium, you absolutely better check the urine output. We have another rule. Here it is. No P equals no K. Earlier, when I had information up on the board about electrolytes in general, you saw me say that potassium affects the heart, the GI system, and the kidneys. Potassium will literally kill your kidneys. So if I have stage 3 kidney failure or stage 2, I'm going to have end-stage renal disease if you give me potassium and my kidneys aren't working that well and you didn't know it ahead of time, okay? So no. I need to actually prove to you that I can make urine before you go giving me potassium, because you have to remember that the way I get rid of potassium, excess potassium, is to pee it out, right? You know that, okay? Now, moving right along, we're gonna go on a little bit further. This IV has to be an 18 gauge. It needs to be large bore, as they call it. If it can't be, it's actually optimum to be using a central line for potassium administration. The patient should be on a telemetry unit, which just means constant monitoring of the heart. Also, we need the patient to have an EKG. I mean, I said that before. You know that this is a big deal because dysrhythmias always go with potassium imbalances. Now, what about the PO thing? Well, the PO is a little bit different. When it comes to PO, you have a couple things to remember. Number one, you must always dilute it with either juice or water. When it comes to the PO, you can't crush it. You can't chew it. Oh God, no. It is not to be crushed and put down anybody's NG tube. I hear you guys telling me horror stories about nurses out in the community working in these long-term care facilities, crushing potassium and sliding it down the tube. Wrong answer, not a good look, okay? So don't do that. All right, then you want to remember that it needs to be given with food. Potassium absolutely has to be given with food. So we can't do, you know, dingy on steroids, as I like to call it. We have to actually give this potassium the way it should be administered safely, and with food is recommended, okay? Now, if you look at your handout, you will see quite a few different numbers. I need you to highlight that 4.0 at the top, right up here, highlight it, because that 4.0 is very important that we keep it there for cardiac and ICU patients. Those two patients cannot afford to have their potassium levels go below 4. I know 3.5 is normal, but you really have to listen to me on this. It has to stay 4 and above, or there's going to be like a little bit of a problem. You feeling me on that? Good. Okay, now other issues when it comes to the patient with potassium, and you're still on the same page. I haven't gone anywhere. I'm just looking at my notes trying to make sure I cover everything you need, is the fact that in the patient with a potassium imbalance, if you're talking about a low potassium, you're kind of going to monitor other electrolytes, and we'll talk about that in a little bit. But for now, remember that this potassium administration, if we're going to give it to a patient, we have a lot of different rules. You really have to monitor the IV site every single hour, and you knew that because we say that anyway. You were supposed to be monitoring the IV site every hour anyhow. But this one is particularly important because when you have potassium, you have a patient who has the possibility of extravasation. And I don't know if you remember that fancy $4 word, but extravasation means that the IV itself could become infiltrated, and because it's a medication, a very vesicant or irritating medication, it can cause burning and sloughing and death to the tissue, and we call that extravasation. So again, it's another reason why it's better to give it through a PICC line, a central line, okay, PICC line. Did you hear me say that? I don't think I said PICC line. I think I did. Yep, I think I did. All right, now the other issue when we look at this potassium, and again, I'm on the same page, is if you go to the side box, it talks about warning, watch potassium levels with these conditions. And so those conditions kind of matter. What it does not tell you on each of these conditions is whether or not it's high or low. And so it's just telling you to watch it with these conditions. So I'm going to give you some highs and lows with that. So if you look at renal failure, and you could use another terminology for renal failure, you could say end-stage renal disease, ESRD, end-stage renal disease, then you know the K is high because potassium is released through urine. If you have renal failure, you're not peeing, okay? Now, if you look at the second one, which talks about hydration imbalances, we know that the most popular imbalance that you would have to know a potassium level with is going to be dehydration. And if you take a patient and you send them outside on a really hot day, let's say it's 108 degrees outside, and let's say it's 88 like it was when I worked at Hillcrest. So I worked at Hillcrest August 8th in 1988. And it was 108 degrees outside. I'll never forget it. It was crazy eights. I don't play numbers, nor should you, but that's what you would play if you did. So 88, right? It's 108 degrees. Can you believe and can you understand and can you comprehend that anybody outside would be sweating? Well, what happens when you sweat? It goes back to what we said. You lose water, but then also sweat has a salty taste if you've ever tasted it when you're running and it goes in your mouth, right? So sweat is sodium and water. I told you earlier, if you lose sodium and water, then the K is going to go high. So this is a simple dehydration situation where the potassium would go up. So dehydration, high potassium. Then it says acid-base imbalances, alkalosis, all K is low. Y'all got it? I hope you got this. I'm not up here like dancing for nothing, okay? So here we go. Cellular damage. Ooh, that's a big one. let's put this word here. This is huge. Boom. Where it says cellular damage, I need you to write the word lysis because it literally means destruction of tissue. And so when you have cellular damage and you destroy the tissue, you are going to make the potassium come out and be very, very high. There are 2 conditions, please write them somewhere on this page, that have that example. Here we go. The 2 conditions that have the example of lysis right in the word is called rhabdomyolysis and tumor lysis syndrome. Both have a high K. Lysis, lysis. Now, I'm not here to give you a lecture on rhabdomyolysis. That would be the renal lecture. But I am here to help you understand words that you probably have never seen on your test or in school or whatever, because a lot of schools don't teach this. So rhabdomyolysis, if you remember your terminology, myo is muscle, destruction of the muscle causing rhabdo, I don't know what the hell that is, so we're going to say renal failure. Sound good to you? Good to me. All right, now tumor lysis syndrome, lysis, once again, lysis is destruction, and you're destroying a tumor, and while that may sound like a good plan, you could get too much of a good thing, and here's what I mean. The patient with tumor lysis syndrome can easily be a cancer patient with a really large cancerous tumor getting chemotherapy, and that chemo can literally destroy the tumor so well that the destruction of that tissue, since tissue, tumors, everything is made of cells, it lyses the cells, destroys the cell, and you saw me write that blood cell on the board, and out comes the potassium. So again, that's what I mean by that. Now, if you continue to look a little bit further, I want you to highlight burns. Burns have always gotten a high K, and you know why? Because if you take me and you burn my tissue, you again have destroyed the cells, and out comes a K into the serum or the plasma. And then so you have a very high K, but during the first 24 hours or so of the burn. Later, you will have a low K, but initially on admission, the K will be high. Accidents. Here I would write the word trauma. When we talk about trauma, we could go both ways. If the trauma is crushed bone, pelvic fracture, literally something fell on me and crushed my bone, well then we're talking about destruction of cellular material, and the K will be high. And if we're talking about trauma and we're discussing the loss of blood, which is also trauma, then you lost your blood cells, and in every blood cell is potassium, so you have a low potassium. So you need to write hemorrhage equals low potassium. Now, then you see surgery. Well, with surgery, you lose a lot of blood, so thereby causing a low potassium. Then you see diabetes. I want you to write the letters DKA. D what? Hello, hello. You in Euclid, Mayfield. You over there in Elyria. Columbus, I'm talking to you. Oh, you're there, huh? Good. So what did I say? Diabetes, DKA. DK what? DKA. What's the K? It's ketone. It's ketones, but it's also potassium. Potassium is high with DKA. I better say that again. Potassium is high with DKA. Now, I want you to add one. Just throw it in there some kind of way, anywhere in that little box. Don't go to that notebook paper. Throw it in the little box. Write blood transfusions. Here, I'm giving you blood. So if I'm giving you blood, I'm giving you blood cells. And if I'm giving you blood cells, then I'm giving you an intracellular component of potassium. So every time patients get blood transfusions, especially with a lot of units of blood, I'm going to have a high K. I got to watch it. Okay, so moving on. Now, if you go to the bottom of the page, you will see quite a few things you need to know. It says watch potassium levels with DIG, diuretics, and IV fluids. Increased K equals irritability, diarrhea, nausea, EKG changes, and dysrhythmias. Here's what I want you to remember. That DIG is huge because Here we go. I'm doing the arm thing. Here we go. When K is low, dig is high. Now, I think I've seen that on a few tests before, so I'm gonna do it again because, you know, I need to exercise anyway. The coronavirus got me all jacked up with the gym. So here we go. When K is low, dig is high. How high is the dig? Above 2. I bet you better know that. It is higher than 2.0. How would you know? Don't be telling me about them green and yellow halos. And don't come telling me about visual disturbances. And don't come telling me because the patient will have a bradycardia. Yes, all of those are true. But here's what's more true. The patient who is toxic on digoxin, which means that their levels are higher than 2, is going to have nausea and vomiting. Vomiting is number 1. Why can't we use green and yellow halos? That's what I learned in school. Okay, I'll tell you why. Because babies with congenital heart defects are on digoxin, and last I checked, they don't talk, and they sure as hell can't tell their colors. So you cannot just be so focused on the adult med-surg lecture that you had that you forget we have something called pediatrics. Okay, hope that helps. Now, moving on, because we have to move. If you can turn the page, you should be on a page that looks like this. And it should say hyperkalemia, okay? So now we're talking about a patient with a very high potassium level, and you and I both know that is horrible. When it comes to this very high potassium level, we've got to do something very, very quickly. Now, what do we have to do? Well, I'll tell you, if it's slightly elevated, we could use Kexalate, as you know. If it is very high, then we're going to have to use an Insulin Cocktail, which I will discuss in a few minutes, and Larry might have to kind of zoom in a lot on this area, but for now, let me go ahead and do the first thing. The first thing is if it's a patient coming in with high potassium, they're going to have several symptoms that you should be looking for. And those symptoms are already on the page, okay? So we don't need any zooming in on this because you already have a handout on it. So you have muscle twitching, weakness, blah, blah, blah. The word flaccid is super important because it means that I'm just like a limp dishcloth. None of my muscles are working. If you look at the picture, because a picture speaks 1,000 words, you can see he has really weak arms. He can't even pick up the weights. You can also see that his, kidneys have been affected, because I told you potassium kills the kidneys. The urinal has no urine in it. You can see he's on telemetry. He's getting his heart monitored. He's got an EKG that looks crazy. So if we look at this page and we just go down the list, because I really want you to go down the list, okay? That's important. If you go down the list, you may remember that on my little magical board here for weakness at the top, I had muscle weakness. And so if I were you, I put that muscle weakness right back in there. So weakness is there, just write muscle on the top. Then underneath the muscle twitching, add brisk DTRs. DTRs, deep tendon reflexes, that's what that is. You already see the irritability and anxiety. I want you to add paresthesia because a patient could have like some numbness and tingling sometimes. And the blood pressure is deceiving, but I'm just going to have you write a little something there. Where it says no BP or low BP, put no PP, okay? So that's how you're doing that. No BP equals no PP, okay? That's been a rhyme I taught you a long time ago. Now, focus, students, focus. Where it says ECG changes, which is really to me EKG, you must remember to highlight the tall peaked T waves. So that's right here. You got to highlight that. Don't write it, highlight it. For the dysrhythmias, I don't really want you to focus on the bradycardia stuff so much, but I do want you to go down there to abdominal cramping and diarrhea, and let me just remind you of what I'm saying. What I am saying repeatedly is that if your potassium is high, the patient's going to have diarrhea and abdominal cramping because the potassium controls muscles and the muscles are moving too much. This is going to be hyperactive bowel sounds. You know that already. So diarrhea, abdominal cramping, hyperactive bowel sounds. Hyperactive, whenever you have diarrhea, you've got to know that, okay? Now, if we go to the treatment, I'm going to come over here on the board and we're going to point to a section of the board that you've got to write it down exactly like I wrote it. You can't mess this up. You can't screw up a letter. You can't mess up a number. You've got to write this down like you have some sense. Now, where did I write mine down at? I wrote my little, what do you call it? Insulin cocktail, I guess. I wrote it down just like this on my packet, and now I'm going to come over here and I'm going to show you how to do it. Here we go. Whenever, and this is a nice tip, whenever our electrolytes are high, it just makes sense to typically do a bolus. And so for the insulin cocktail, for the oh my God issue of a very high K, we are going to hydrate the patient first, and this will be a bolus. You will be giving a lot of fluids to your patient to get this patient to calm down. Now, you have an EKG on the patient when they first came up, and that EKG will tell you if at the same time you're giving a hydration, you're doing your IV hydration, if right after you get that IV in and that fluid hung, it will tell you, the EKG will tell you, based on any dysrhythmias, if you also have to give calcium gluconate, PRN. Hear me clearly. Calcium gluconate can only be given IV. So of course you need to do the IV hydration first. This is true with almost every single high electrolyte anyway, but in this case, the EKG is going to show you something outrageous. And of course, you need to make sure you give that calcium gluconate PRN. So pay attention to the EKG to kind of guide your hand. Now, if there's no EKG drama, then hydration is first. You know, I need to give the calcium gluconate. And then look at this. We give an IV push of 10 units of regular insulin. I'm going to say that again because you already know the only insulin we can give IV like that is regular. So you would never check off Lantus. You wouldn't check off, you know, what is it, NPH. You also know it has to be IV because this is an emergency. So you would not, hello, check off sub-Q insulin. You wouldn't do that. It has to be IV push. 10 units of regular insulin. And then you see, if you're going to give that much insulin, get ready for your patient's blood sugar to crash. And so you're going to have to give an IV push 25 grams of D50W. Now watch this. Both of these are IV push. You know good and darn well you cannot give that fast. You have to give it over 5 to 10 to 15 minutes. Super slow. The only medication you give in a slam is adenosine. This is super slow. This is a lot, by the way. It's like 20 cc's of fluid. You have to give it super slow. If you give someone insulin, you know their sugar's going to crash. That is why we're giving them the sugar. The sugar has nothing to do with potassium. It has everything to do with the fact that insulin decreases potassium, but I can't give a patient IV push insulin and think I'm still going to have a nursing license unless I follow it with D50W, okay? These two are often mixed together, okay? And if they are, then it's going to be a 15-minute to 20-minute administration. Now, look what else I wrote. Loop diuretics, you know what that is. That's furosemide, bumetanide or bumetanide, Lasix, right? And of course, you heard me saying generic words because that's what's on the test. And these loop diuretics are going to go ahead and help that patient get rid of the potassium. And so that will help. You know that these are potassium what? Potassium wasting. You know that. Potassium wasting. Yay! You know that. I don't have to teach it, but I wrote it just in case you forgot. Kexalate is a cool drug. It's not going to be Kexalate on your test. No, it's going to be sodium polystyrene. I know, crazy. Don't worry, you have a handout already. Don't go crazy. I'll show you the handout in the same packet, don't worry. But it is Kexalate. What kind of drug is it? It's actually an enema. This enema that you give the patient, you have to know your little, procedures. So we put the patient in a left lateral Sims and we give them the enema. We tell them to retain it for 20 minutes. Well then, if Kexalate is such a great drug and it's indicated for a high potassium, why can't we just give them the enema and send them out of there? Well, no, you can't do that unless it's a mildly elevated potassium, because remember, Kexalate is too slow. It will work really well tomorrow, okay? In fact, I would tell the patient, I don't know if you want to go to work tomorrow because you're going to be pooping every 20 to 30 minutes, maybe even every hour. It's a laxative that's going to take the poop right out. Not really a laxative, but it's a medication that gets rid of the K through the stools, you know what I mean? So this Kexalate is a little too slow. I need major insulin cocktail, little magic cocktail, if I have a potassium that's pretty high, like 6 or higher, right? Now, what might need to be done depending on how bad this potassium is? Oh, dialysis. Yeah, dialysis may need to happen here. Dialysis, even, get this, sodium bicarb. Now, I don't know if you can see that very clearly because it's at the bottom of my board, but you should see me pointing to the sodium, and it says NHCO3. That is sodium bicarb. If your patient is acidotic, okay? So that will help tremendously. But again, it's a PRN drug. It is not as common as the rest of this stuff. So dialysis, if it's really outrageous, after you've done your insulin cocktail, because dialysis takes a while to set up. So I can't just, you came to my ER 5 seconds ago and I'm going to do dialysis. No, I need special tubing, and you know that already, ports and everything else, a central line, you name it, I got to have it. And that's not what people walk in with, okay? Now, number 7 talks about a low potassium diet and falls precaution. You remember the muscle weakness. I told you that. Brother man on your page can't even lift the weights. So when we talk about false precautions, we don't need to let this patient go to the bathroom. They're going to fall on their face. They have no muscle action until you get rid of this, okay? Then when it comes to like a low potassium diet, it makes sense, right? Because we have a hyperkalemic patient, but it does not mean anything unless you know your high potassium foods. So come on with me because I got a trick. Here we go. I take the word potassium, like you need to take the word potassium, and I put all of the extremely high potassium foods on this little board with that mnemonic. So P for potatoes, and it doesn't matter what color your potato is. It could be a sweet potato, an orange potato, a white potato, whatever. It's potatoes. It's number 1 in potassium. Oranges, tomatoes, number 2 highest in potassium is avocados. Now, so the P is for potatoes, the O is for oranges, the T is for tomatoes, potato, tomato. And for the potato, the way I remember it is I tell you, potato, potassium, potato, potassium, potato, potassium, potato. Okay, I'm sorry, I get so lost in this stuff. So potatoes, oranges, tomatoes, avocados, and those are huge. All 4 of those are huge, but we're gonna keep going. We got S for spinach, another S for strawberries, and then I kind of went crazy, and you have to stay with me. If you went to the bathroom, you're gonna screw this up. So here we go. I and U are 2 letters that I put together, and what I say for this one is I know and you know bananas are high in potassium. I know and you know that. So I put them together because you know what? They're never on a test. It's because we know it. Yeah, when you know stuff, you know it's not going to be on a test. Now, because you learned this in preschool, so they're not going to put this on a test. Now, you have 1 letter left. It's M, and that's your melons. I put green just because, melons are green on the outside. So those are all the foods that this patient that you just gave an insulin cocktail to should not be eating. It shouldn't come up on their dinner tray later on if they stabilize, right? Got this. All right. Now, if you look at your handout, and again, we are still on this handout. If you look at this handout, I need you to write a couple more things, nothing outrageous, but some things that I think you would appreciate maybe later on. Maybe you'll see it on a test, who knows. But here we go. I want you to write down a few really very popular things that would cause a high K. Here we go. A high K is very often caused by CKD, AKI, end-stage renal disease. Chronic kidney disease, acute kidney injury, end-stage renal disease, renal. Here's another one. Your endocrine, your SIAD, whoops, I lied, forgive me. No, I didn't lie, I was telling the truth. SIDH, or adrenal insufficiency. This is another word for Addison's, but lately you've had to know both words. Okay, so the potassium is high in those conditions, okay? Another condition that potassium is high with, you heard me already say it, and that was DKA. You heard me say dehydration. You heard me say tumor lysis syndrome and rhabdomyolysis. So, you know, I already told you those. So you should be okay. And you heard me say the burn patient. Okay? All right. Now, one more thing that I didn't mention, and I just want to make sure you know. I don't know if you know that oranges and strawberries, these two fruits, are citrus fruits. So I thought I'd mention that because you kind of might need to know that a little later. So citrus fruits are very high in potassium, okay? Now, as we ponder a little bit further, I want you to turn the page. Actually, do one more thing. I know you're sick of me, but do one more thing. Last thing I want you to put is that the insulin will activate the sodium-potassium pump. You kind of got to know that. Insulin activates the sodium and potassium pump. Okay, so those things you kind of sort of care about. Now, you heard me talk about Kexalate. Why don't we go ahead and turn to the next page, which talks about Kexalate. This is a quickie. Everybody loves quickies. So here we go. When it comes to Kexalate, you have to remember that the generic word, Kexalate, means K exits the body. K exits the body. But, as you can see, there's a generic written right there, and it's sodium polystyrene. And so when you go talking about sodium polystyrene, that's what's on your test, because all tests have generics. Now, when you look at this medication and you see all the different ways I could give it, I'm going to be honest with you. Having worked a long time, you need to know in the bubble off to the side that if you look at what it says I'll have to use Kexalate either PO or rectal. Highlight rectal, remember it's an enema, okay? Then I want you to go down to the very bottom, because you have lots and lots and lots of room, and I want you to write a couple things about Kexalate. You're gonna write that it's too slow if potassium is greater than 6. It's way too slow if the potassium level is a lot higher than 6, okay? Now, so if you come in and your potassium's elevated, and we want to take care of you, we will give you Kexalate to go home with if it's mildly elevated and you have symptoms, obviously. But if it's really, really high, 6.2, 6.8, 6 point whatever, it's going to be a need to give you this insulin instead. Okay, so it's really too slow for it to be, you know, to have an impact. Now, what does it do? It basically causes the potassium to go from the intracellular component to the extracellular component, and then it binds with the stool and it exits the body. It's that simple. So if you have a patient that has been given Kexalate, you better make sure they can poop and they're not impacted, because you have to assess their bowel pattern to make sure they can actually have a bowel movement. Because if you give this to somebody that's constipated and they have a bowel impaction, then we're going to probably have a very serious problem with a ruptured bowel. Okay, so this would not be good. All right, this would be horrible because the potassium would kind of cling in there, and or the Kexalate would just kind of sit in there and not do anything. Now, just remember, even if I give Kexalate, I still started out with an IV hydration. And remember that the positioning for Kexalate enema is left lateral Sims, and you taught the patient to retain it for 20 minutes, okay? The number one side effect is frequent loose stools, even diarrhea for some people, but definitely frequent loose stools, okay? We usually give it 30 grams for the dose, but I don't think you have to know that. All right, now I need you to turn the page because we're moving. I don't know about you, but we're moving. So if we turn the page, there's a little bit of information about diuretics and the classes that they're in. Can you please go down to, on this page, the very bottom. On the very bottom of your page, where the diuretics are listed, you will see that there is a page that has quite a few cool diuretics. You see that it says loop diuretics. Now I'm going to tell you like this. I actually need you to highlight the one that says bumetanide. I have given you a handout in here about it, but I still want you to highlight it. Bumetanide is Bumex. Furosemide is Lasix, right? Now that's the loops. On top of the box, write K wasting. That's how you do that. K wasting on top of that box. The one next to it is, and I want you to abbreviate it, HCTZ. I'm going to show you what I'm talking about. The box next to it says thiazide. An example of a thiazide diuretic that half of Americans are on because they have high blood pressure, and it is the drug of choice for high blood pressure, is HCTZ. It is potassium wasting as well. It is considered the #1 drug of choice for high blood pressure because it's going to get that water right off the body, okay? So you're going to do that. That's hydrochlorothiazide, the very first one, and of course there's some others there. You see them. And then potassium sparing, OMG, huge. You're going to notice that the two boxes side by side, one says triamterene amiloride, the other one says spironolactone. Think of spironolactone as potassium sparing. Okay, so, you know, get that spare thing going on. That is huge. That is also in this packet already. Now, let's go. Chop, chop, let's go. If you turn the page, you should be on the wonderful little diuretic water slide. And what I want you to do at the very top of this page is I want you to write daily weights, because that's exactly what we need to do with this patient, daily weights. And it sounds cute, but let's be serious. When you discharge a patient from the hospital, my patients ain't going nowhere unless they can prove to me that there's a scale in their home. Their daughter, their son, their husband, whoever, can send a picture of that scale for me to see in that house, and I will let them out of jail. I tell them this because honestly, daily weights could have prevented almost every single hospitalization for patients with CHF, for patients with pulmonary edema, for patients with kidney failure, for liver failure. We could have figured this out a long time ago if you weighed yourself every single morning before you got dressed, but after you urinated. I could tell what your weight trends will be if you had just did that. but people don't do that, and that is huge. So daily weights. Now, here we go. Here's our conversion. We told the patient to weigh themselves every day. What are we going to do with the information? Well, first of all, we know